One. Sir, we are live now. Now we can start.
Good morning, all. Welcome to the ASSI Global Outreach Program. Another interesting session with the Association of Spine Surgeons of Nepal. And your moderates are Dr. Gururaj and Dr. Ankur Nanda for today. And we will start with the welcome address from the Bombay Spine Society President, Dr. Ketan Badani. Dr. Ketan Badani.
Hello, good morning, everybody. On behalf of the Bombay Spine Society, I welcome you all to this interesting webinar that we are going to have. It's a bright morning and it's the best time to do any academic deliberation with a fresh mind. The Association of Spine Surgeons of Nepal is very close-knit with the ASSI, and we are not only neighbors, but we are like brotherly spine surgeons. And I welcome you all to this session. This global outreach program has been made with an intention of making the ASSICon 2024 as grand and as more educative as possible. So without wasting much time, I would pass on the the mic or to Dr. Binod to give an introduction and welcome on behalf of the Association of Spine Surgeons of Nepal.
Dr. Ketan, before that, Dr. Srivastav, sir, that's President-elect from Association of Spine Surgeons of India. He will welcome all the faculty and the delegates, and then we will.
My apologies.
Thank you very much, Dr. Guru, Dr. Ketan, and a very good morning to all the faculties and all the participants from ASSI, BSS, and Nepal Spine Society. It is my proud privilege to welcome you all to this prestigious session. Now, ASSI and BSS, they have organized this conference ASSICon 2024 in such a way that there should be maximum academics and quality academics, and that's why different societies of the world, different spine societies are participating, even though the main conference has not started. But see the efforts of all of you that we are sitting in the very early morning and discussing very important things. This will raise the bar of academics, in spine world. And I think it's a very good move. And this whole program has been crafted very nicely by the Association of Spine Surgeons of India, Bombay Spine Society. And this is going to be a very successful conference. I welcome all of you to please attend ASSICon 2024, and you will find the peak of education, peak of academics in this conference. So most welcome to all of you, and all the best for today's academic session. And thank you very much for inviting me. Thank you all of you to finding time and attend this academic. Thank you very much, all the faculties from both the societies. Thank you. Without wasting any time, I hand over the proceeding to Dr. Guru. Thank you.
Thank you, sir. Thanks for your encouraging words. So we'll start with the welcome address and the talk from the President of Association of Spine Surgeons of Nepal, Dr. Binod Bijukache. Over to you, Binod.
Thank you, Guru.
Meanwhile, when you share your screen, you can maybe talk about ASSN a bit.
Yes.
Yeah.
Thank you so much, ASSI and BSS for including ASSN in this global outreach session. And we are really privileged, and this is our honor to be a part of this ASSICon 2024. So on behalf of ASSN, I would like to extend our best wishes for a grand success of ASSICon 2024. So how do I share? Is my slides visible?
No, share screen. Have you done share screen? Can't see, Binod.
Yeah.
Yeah.
Has it come?
Yes. Can you go to slide share?
Yeah. Okay.
Yeah, we can see that.
Okay, good morning, everyone, once again. So, this is a very interesting title for the presentation, but its content would be kind of debatable since there is no clear-cut guideline regarding what to do and where to do in multi-level disc herniation. So, in lumbar disc herniation, if it is at the level of 2 or more, and it's herniated through the annulus fibrosis causing compression or deformation of the dura mater, it's referred to as a multi-level. And the reported incidence is 12 to 30%, 33%. But what percentage of these discs are symptomatic is still questionable. But eventually, it will definitely lead to multi-level lumbar spinal canal stenosis. There are ample of evidences that in support of non-surgical treatment is as good as surgical treatment. So the initiation of any lumbar disc herniation should be to exhaust non-operative measures. The only absolute surgical indication is the cauda equina syndrome, which accounts to less than 1%. And if the non-operative measures failed, exhausting the epidural steroid injections or selective nerve blocks, that could be a consideration for the surgical decompression. But the crux of the treatment in multiple disc herniation is identifying the culprit disc. But unfortunately, there are no reliable exams or tests or investigations that could identify the symptomatic or the offending disc. So it has to be a combined effort of proper and diligent history taking and diligent clinical examination after ruling out all the vital signs and workers' compensation litigation. But both of these has to concord with the findings of investigations and the diagnostic tools. It's very important to have a very diligent and precise clinical examination to identify the offending disc, and in which the mapping of the pain radiation and the sensory changes are very, very important. So far the sensory changes are, indicated like in L4 and L5 in S1 are always below the knee and rest is above the knee. Likewise, if the radiation is there, L4 is anteromedial, L5 is anterolateral, and S1 is posterior. If there is involvement of S2, S3, then that indicates that the impending cauda equina syndrome. Motor exam is important, especially, the examination of five key group of the muscles: hip flexors, knee extensors, ankle dorsiflexors, great toe extensors, and ankle plantar flexors. In addition to the examination of the reflexes, knee and the ankle jerk, which corresponds to L3-4 for the knee and S1, S2 for the ankle. So basically, it's important to have the diagnostic rules. So there is one article on clinical classification of low back pain, in which, for particular to the disc herniation with the nerve root involvement, straight leg raised test positive for referred leg pain, and 3 out of 4 history of physical examination findings has to be there. That is dermatomal pain location in concordance with the nerve roots, and corresponding sensory deficits, reflex, and the motor weakness. But all these physical tests have, very poor diagnostic performances, whereas the SLR has showed high sensitivity and cross SLR has showed a high specificity with the low sensitivity. Plain X-rays are important just to identify the instability, but the gold standard is MRI, where in this particular case, you can see that L3, 4, 4, 5, and 5 S1 discs are herniated. And there is one article regarding the accuracy of the coronal magnetic resonance imaging, diagnosis of multi-segmental lumbar disc herniation. But this article is also not very convincing in identifying the symptomatic disc. Myelocity is indicated if MRI is contraindicated, and this is invasive, and electrophysiology is indicated in non-corresponding MRI findings, just to differentiate metabolic or central or peripheral neurological causes. So there are certain diagnostic tools, especially the selective knob root block, that can identify the symptomatic offending disc, but this is invasive and the success is closely related to the clinician's expertise. But the provocative discogram has been, you know, uh, proposed for identifying the symptomatic disc. And this is the Adams nucleogram, which has shown that there are 5 types of the discs: cotton ball, then there is a lobular type, then fissured and ruptured. And in between these 4, there is the intermediate, which is the irregular type. So cotton ball and the lobulated types are the normal, whereas the fissured and the ruptured are the abnormal and could be a symptomatic test. But the CT discography is the gold standard for identifying the degenerative disc. So there are different types of the disc degenerations have been identified in the CT discography. And there is one article on treatment of multiple level disc herniations, which has concluded that it's very imperative to identify the painful disc, and to identify the painful disc, discography plays an important role. But it has its own drawbacks because it leads to the accelerated disc degeneration. And so it should be taken with a pinch of salt. So this is one case where the patient, 45 years old lady, presenting with the back pain radiating to the right lower extremity. Motor exam showed 2 dorsiflexions of 4/5, sensory hypoesthesia at anterolateral leg and dorsum with the foot, and ankle jerk is normal and bowel bladder is normal. Though there are disc herniations at 3 levels, but its symptomatic disc, which is corresponding to the clinical finding, is at L4 and L5 only. So to conclude my presentation, what to do in multi-level disc herniation: always exhaust non-operative management. And if the surgery is opted for, in case of the failure of non-operative management, there has to be a justifiable indication. Then if the surgery is opted for, then you have to identify the symptomatic disc, which is one of the most challenging problem in multi-level disc herniation. So it has to be individualized to the patients based upon the clinical findings, imaging, and the diagnostic tools. And everything is based upon the surgeon's experience and the preferences, whether you go for the open, micro, or endoscopic decompression. Thank you.
Thank you, Dr. Binod, and thanks for finishing within time. And the next talk will be by dear friend Dr. Ayush Sharma. So he will be going to talk on recurrent disc herniation prevention and management.
Yeah, so Vinod, please unshare so that I can share my screen. So thank you, Guru, the friends from Nepal. It has been a pleasure to visit Nepal recently, and of course the whole team of ASSI and BSS and Vishal is doing a good job. So my talk is on recurrent disc herniation, how to prevent them and how to manage them. So this is one patient, 4th November, exactly almost a year back. He presented with this picture. There's a big disc prolapse. You can see almost the whole canal is getting filled up with disc. And our standard approach is endoscopy. This is what we did. You can see this is just lateral to the root. Even if once you go in such big disc prolapse, you can already see the disc is simply just waiting to be taken out. And that is what we did. We took out the fragments using interlaminar endoscopic approach. And there goes another fragment, and so another big fragment. And this is the end of the discectomy after removing quite a few fragments. The fragment on this side, you can see they are pretty big fragments once they come out. So this is, you can see the big juicy fragments, they were taken out. By end of the surgery, we almost took 4 big fragments, and patient went on to do very well till he presented almost like a few days back. which is 21/11/2023, with a radiculopathy, and we got a MRI done, and this is what we saw. So this is how sometime it happens. And again, because we have already done a endoscopy, and interlaminar space was violated, this time we went through a tubular approach, and you can see this is a 5S1, because I had the virgin bone on one side. I can just drill a few amount of bone. Instead of going through the interlaminar window, I can go through slightly bony window, still keeping everything intact. And we did a revision discectomy. So what is recurrent disc prolapse? If you go by the definition of it, the recurrent lumbar disc herniation is defined as occurrence of herniated disc material at the same level after a defined pain-free period of 6 months from index surgery. Just like the case I showed you, patient had a pain-free period of almost a year, and then he presented to us with a disc prolapse. If you look at the literature, the incidence of this recurrent disc prolapse, it can be very, very variable, and it can vary from 0.5 to as high as 25%. And most of it, like the case I showed you, occurs in almost the 50% of it occurs within a first year of the index surgery. And I've taken all this reference from this very beautiful article. If you want to read about it, the treatment of recurrent disc prolapse, a systemic review. So basically, this is a systemic review of these cases. So what are the causes? Where do you expect them to happen more frequently? If you have a large annual tear, like the case I showed you, if you see the tear must have been very, very large, because if you see the whole of the canal was almost filling up. So it has to be a large annual tear. And if you have a large annular tear, you tend to get more disc prolapse. That's why, at least for endoscopy surgeon, what we do, at the end of the discectomy, what we try to do is annuloplasty. You go all around the annual tear and try to sort of use the high frequency RF to shrink it as much as possible. No one knows if it helps, but at least we try our best. Then if you have a progression of degenerative change at the surgical site, even after doing your discectomy, if the disc area sort of continues to degenerate, continues to sort of collapse, you have a more chances of having a recurrent disc prolapse. Patients with comorbidities, diabetes, and all, they are more likely to have a recurrent disc prolapse. Smokers, working status. If you have a patient who is a manual worker, who bends forward every day, who puts more pressure on his spine, they are likely to have more recurrent disc prolapse. Even the bony condition of the age of the patient also is one of the defining factor. And if you have modic change in the spine at that level, that can also result in chances of having a recurrent disc prolapse. Not only that, we went into literature, and it was very interesting to find the recurrence of disc prolapse also depends upon the type of the primary surgery done. So this is a paper where they have compared 3 different techniques. First was microendoscopy, second was a microdiscectomy, and the third was the open. And they sort of concluded that the recurrent herniation was more prevalent in microendoscopy group, although it was not significantly different. So that is it. So maybe because when you are doing endoscopy or microendoscopy or surgeries through a limited visualization, you might leave few fragments. That could be the reason. But most of the literature says they are not significant when compared to other techniques, but they might be slightly higher when you are using the minimally invasive technique. So coming to the treatment options, we all know, my good friend just talked about the treatment option. We all know that if patients has some pain or just a manageable problem, it could still be a non-operative option. You still tend to give non-operative option. In my, in whether you're in India or in Nepal, it's not easy to convince them for a revision surgery. And root blocks, if they have one, most of them, they come with a radiculopathy. Root blocks most of the time work very, very well. It is sort of a in-between path between your conservative treatment and your operative treatment. But if you do have to offer surgery, it can be for patients who have presented with a neurological deficit and a patient who are not sort of getting better in spite of giving the conservative treatment. So let's see what are the outcomes of surgery. You have a lot of option. Again, you can do a simple revision discectomy. You can do a minimally invasive discectomy. You can do a posterolateral fusion. You can do a TLIF or a minimally invasive TLIF. And again, I sort of looked at what was the treatment outcomes, and if one of the technique is better than the other. Even a simple discectomy for a revision surgery for a reprolapse has a good outcome, almost between 70 to 89%. If you choose a minimally invasive approach, the outcome sort of gets slightly better. It is between 81 to 90%, not much different, but slightly better. PLIF has a slight, is also equally good, and they say that the MGO scores improved between 70 to almost like 70%, and it compared to TLIF, it was more cost effective. When it came to TLIF, the good outcomes ranged between 68 to 93%. So if you looked at the revision surgery, and if you compare simple discectomy versus fusion, they both have almost similar outcome and similar complication rate. However, discectomy, if you do a simple discectomy, it has shorter operative time. It has a shorter length of stay for the patient. It needs lesser hospital charges. And fusion should be considered when you have an instability, when after discectomy there is a deformity in spine, or if you have chronic low back pain along with radiculopathy with modic changes sort of thing, then you might consider the fusion in these cases. This is another case. This was a patient. This was a patient. We have done an open laminectomy, and after 2 years of the surgery, he presented with a L4-5 reprolapse. This is back in 2021, and you can see a big laminectomy defect, because that was the time we were doing, and with a bony osteophyte. He's a young patient, 30 years old. So in spite of, maybe a fusion surgery might be recommended, but we went with an interlaminar approach. The good advantage of doing an endoscopy interlaminar approach is that, you can see this scarring, but, the hydrodissection sort of allows you to, even sort of get a better visualization and even work between the scars if you have to. And that was done. You can see just the nerve root, which is just coming into place. And then if you see, the nerve root is now almost adherent to the scar. This is the lateral edge of the root, which you can see. The first thing was to sort of mobilize the root so that you can get a plane to work between the scar and the root. And you see, this is the nerve root, which is pretty flat, and it is stuck with the scar from the previous surgery, as the previous surgery was open surgery. So this RF really is very, very safe tool. And what I'm doing is sort of working my way through this endoscope with the scar tissue. Once I have enough space, you come across the bony osteophyte, which I showed you was on the X-ray. We use this terafins to sort of break through the bony osteophyte, and you can sort of see this on the C-arm images. How you can see how this sort of completely breaks the osteophyte. Once you have broken through the osteophytes, all you need to do, this is the piece of osteophyte which is being taken out. Once we have broken through the osteophytes, all we needed to do is to perform a discectomy, because now you have everything defined with you. And this is how the discectomy was done. And once after the discectomy, we just made sure that the root mobility is good, and this is where the root mobility will come. And the patient basically, I don't know if you can appreciate, but this is the root, which is free, mobile, and pulsatile. And this is the patient, because you have done an endoscopy surgery, they are most of the time very, very comfortable, even in a revision scenario. And this is my own cases where we have gone from doing from a complete open to revising it with the endoscopy. And in terms of at least the cosmetic appearance, it is a huge, benefit. You can see how the skin scar differs. This is my strategy when it comes to these cases. Early diagnosis is a must. please don't discredit patient. No one wants to have a reprolapse. We all want none of our patients, once we have touched them, should come back to us. But it is very important that if they tell them there is a problem, try not to discredit them. Try to see, try to investigate, try to examine, document your surgery. Like I showed you, I had the video of my first surgery. If you know the road ahead, it is easy to navigate. Of course, you might get a patient who has been operated by someone else, but if you have operated your case and 1 year down the line, you might not remember anything about it. But as such, we try to document all our surgery so we know what was done and what is the best approach possible. As much as possible, choose a virgin approach. What I like, the way the two cases I showed you, I always go through a slightly different approach. If an open surgery is done, maybe I will prefer an endoscopic approach. If I have done an endoscopy surgery before, as I showed you, I can just dock the tube on the bony anatomy, drill a part of bone, again go through the virgin approach, because you can work through the scar like the case I showed you, but it's much more easy if you're choosing a virgin approach. Fusion, I don't hesitate to fuse them, but that remains my last resort. As much as possible, I will still revise the recurrent disc prolapse with a different approach. But if a patient has chronic back pain, or along with the recurrent disc prolapse, if there is instability or deformity, I might not shy away from fusion. So these are my strategies for recurrent disc prolapse. Thank you so much.
Thank you, Ayush. That was a nice presentation. So may I call upon Dr. Arvind Kulkarni, senior spine surgeon from Mumbai. So he is going to talk on persistent radiculopathy after lumbar disc surgery. Over to you, Doctor.
Yeah, can you see my slides?
Yes.
We can see.
Yeah, so that was a great talk by Ayush. So a very bright morning to the faculty and the international audience. So discectomy is one of the simplest, easiest, coolest, and most common surgeries that we do in our spine practice. However, this particular surgery has some unhappy quotient associated with with the surgery, because of which I get goosebumps sometimes when the patient gives me a call after a few days after this surgery. If a patient has undergone a TILE for a tubular decompression, etc., I'm not concerned. But when a patient who's undergone a discectomy calls up, it really gives me a heart attack, because of its because it is associated with this unhappy quotient. So the patients have a lot of expectations following a discectomy. They are utopian in nature: relief of leg pain, disability, early return to work, early return to social life. Overall, a very happy patient. So this, from the patient side, this kind of heightened expectations are as a result of aggressive and unscrupulous marketing by right from the quacks to the 7-star hospitals, and from the surgeon's side, because of tremendous amount of literature which gives a big thumbs up to this particular surgery. However, is this true? So this particular paper is very weighty in terms of unraveling the truth. It gives the core hard truth. I give it importance and I call it weighty because of mainly two reasons. One is it is published in a very high-rung journal, that is Nature, and it comes from a socialistically managed medical admin, that is Canada. So Canada is a socialistic, has a socialistic medical culture where the surgeon doesn't have to impress the patient doesn't have to impress the surgeon. So this is a large study involving more than 500 patients who had undergone a discectomy. This is a multi-centric study, again giving more credibility to it. And these are lumbar discectomy patients who were evaluated at baseline and at various intervals of time for leg pain, back pain, and disability. And the hard truth is, though there is some relief in the pain, in terms of pain from average of 8 to 6 at the end of 3 months, almost close to 1/4 of these patients, 25% of these patients are not happy at 3 months, and this unhappiness is sustained for almost 2 years. So this is the core truth. So this is the trajectory of pain relief. And this is resonated in many other articles which are weighty in character in terms of the journals in which they were published. So why does this happen? This kind of expected leg pain in patients who undergo lumbar discectomy, that is basically because of sustained mechanical compression causing demyelination and sensitization of the root as a result of these chemicals that are released by nucleus pulposus. So this is something which is expected. This is called proportionate pain. If you classify post-operative pain following discectomy, you can classify it into proportionate pain, that is expected pain, which occurs in 25%, and disproportionate pain. So this is something which troubles us most of the time. And these are the various reasons why patients have disproportionate pain after surgery. Disproportionate pain is pain which is something which is beyond what is expected following a discectomy surgery. I'll go by one. So this is an interesting situation. So wrong diagnosis. So this patient has a L5 root pain. It comes on extension, basically a claudicant leg pain. So if you're tunnel viewed, then you will just see the right side L5-S1 disc herniation. Patient has L5 pain, remember, as I said. But if you just stretch your eye to the foraminal side, you will see there is a foraminal disc here. So it's very important to meticulously examine the patient, have presence of mind. In such a situation, just don't do a L5-S1 decompression. You also take care of this L5-S1 foraminal disc. So these can come as googlies and can continue to be a source of pain if not attended upon. Or the wrong diagnosis would be such that it could be somewhere else altogether, like the sacroiliac joint, hip, knee. It could be a vascular pathology that you would have missed. It could be coincidental or it would be isolated. The next would be a wrong level surgery. So when something like this happens, just go back to the images and see whether you are wrong in terms of choosing your level. This should actually happen intraoperatively. Doing something like this in surgical science, in spinal science is a sin. So this patient had a L4, L5 disc herniation, but underwent a L3, L4 discectomy. And this can lead to a medical legal suit. So this, be very careful not to see that such a thing never happens in your practice. And surgical checklist is something which can help you in preventing such errors. So this is the story of a patient who underwent 7 surgery. I call it Saat Khun Maaf. So this patient had an endoscopic discectomy done by the same surgeon 4 times, a micro-lumbar discectomy done by the same surgeon twice, and ultimately, with the blessings of Pashupati Nath, we gave him salvation by doing a TILIF on this patient. So he had 7 surgeries. So inadequate decompression, and none of the surgery did have pain relief. None of the 6 surgeries. So that is one. Again, undiagnosed instability. So this patient came with cauda equina syndrome at that point of time because of his various comorbidities. He just did a discectomy, but we did have it in mind that this patient has a vacuum sign, and this patient ultimately ended up in significant instability and had a TILIF done. So that is something which can cause sustained leg pain. Residual disc. So this happens in a best of friends. So this is an ophthalmologist who had a right side L4, L5 disc herniation. Very simple, straightforward, cakewalk kind of surgery. We did a tubular discectomy, and patient was all right for a while till the next day when he had again disproportionate pain, not proportionate to what you see post-operatively. So we did a MRI, couldn't get up of the bed. So we did a MRI, got his disc out, which was just hanging out through the annulus. So your case selection may be wonderful. You must have investigated the patient very well, but you might end up having such kind of disasters on table. So this is the executional disaster. Here you can only call for divine intervention to relieve you. So epidural fibrosis is something which is blamed again and again, but you should remember this doesn't occur the next day after surgery. This takes time to occur. It might take about 6 weeks to 6 months. And this is basically as a result of scarring because of inflammation around the nerve root. And there are various techniques to decrease epidural fibrosis, that is to prevent basically inside less scarring. This is done by minimal access procedures, using topical steroids, proper hemostasis, etc. Then comes these non-organic causes such as depression, overweight, workers' compensation patients. So here it is the surgeon's choice whether to go ahead and operate on these patients or not, or probably operate after a careful preoperative evaluation and a counseling session, again post-operatively. So this is totally non-organic in nature. So basically the take-home message is respect the natural history. So we have heard of this waiting list syndrome occurring in the socialistic countries where the patients wait for their turn to get operated, and the natural history saves them from surgery. So those patients who really need surgery will definitely come back to you, and they should actually come and beg for their surgeries, request for these surgeries, because at that point of time you should be able to counsel, and they should be having their ears to get counseled in terms of expectations of after surgery, in terms of the unhappy quotient, the possibility of recurrence, and the aftercare that they need to pay attention on. And in terms of surgeon, it's case selection that is important, the right patient, the right surgery, and the right post-operative rehab, so that such a occurrence doesn't happen. Thank you.
Thank you, Dr. Arvind. That was a very nice presentation, and I think the article which you quoted was a really eye opener. So this session now for 3 talks, it's open for discussion. If you have any questions, please. Yeah, so I have a question for, we'll start with Arvind. Arvind, if you do a discectomy and after a week, patient comes back with the similar kind of radiculopathy which was there preoperatively. So what is your standard approach? Like, what is your step-by-step approach for these patients?
Yes, so in these many years of practice, I can kind of, with a gut feeling, I can relate as to whether it is a proportionate pain or a disproportionate pain, which I talked about. So I ask them, even if there is 10 to 15% relief, and if they are mobile, so I would not give it much attention. But the patient comes on a wheelchair, if the patient is really weeping and their SLR is strongly positive, then I will not beat around the bush. I'll get an MRI done and I'll go straight ahead, because most of these patients are middle-aged. They want to get back to work. We just don't want to treat them unnecessarily conservatively for long, and this is not going to heal. So if it is disproportionate to what I should see after a week, I'll get them investigated, and if there is a disc, I'll go ahead with a redo discectomy. Okay,
Ayush, so continuation with this question. So you do an MRI and you see there is a disc looking like material which is there in the canal on the same side. So how do you decide whether it's a fresh disc, recurrent disc, or a residual disc, or just a annular bulge which is? Ayush? I think Ayush is not there. Okay, Satyan, you wanted to ask something, yeah.
Yeah, I wanted to ask Dr. Arvind, most of the time when we do discectomies, we never do these big extruded disc fragments, because we know that conservative management most of the time takes care of them. So we are always operating on patients who have old herniations, which are like subannular type of disc herniations, or a little quite degenerated discs in those situations. So, how do you counsel these patients? Because they are very tricky in terms of whether only a decompression or a discectomy may be enough, or whether they would end up needing maybe a fusion and also getting adequate pain relief in these patients.
So fusion is out of questions. Fusion, unless the patient is a back dominant leg pain, I don't do fusions. I, as much as possible, do a discectomy. And these kind of subannular herniations, the annulus is just waiting to rupture. So the minute you put your nerve hook in, it just pops out. So these are the cases. So that if you're coming to a situation where there are contained discs, where there is a uniform circumference of this annulus, I'll look and see whether these patients have claudican type of a pain or a SLR positive kind of a pain, flexion dominant pain or an extension dominant pain. If there is claudican pain, I just decompress the nerve root. And if it is a flexion dominant pain, then these are bad patients. These have a slightly higher incidence of recurrence. They have less satisfaction levels compared to a patient who has a sequestrated disc. So that again has to be counseled very well.
Okay, we have a rare situation here. Dr. Vishal Kundrani has a question.
Hi everyone. So wonderful talks from everyone. Now, after 20 years of practice, Arvind, and I'm sure most of the guys here have been practicing more than 10 years already and doing a lot of newer and newer techniques. What are those one pointer that in a good selected patient, a nicely selected patient, a good compressive radiculopathy in a PIVD patient, how do you ensure that this patient will not land up in recurrent disc or will not become an unsatisfied patient?
So counseling.
I mean, not surgically, but are there some pre-operative tricks that you should ensure, whether it is MMPI that you follow, or it is counseling that you follow, or it is you rely completely on technique? After a nicely selected patient, there are still so many unsatisfied patients. How do we ensure that the satisfaction level increases?
I take more time in counseling a patient with the disc herniation than a patient who needs surgery for scoliosis, because these can really break your head. So every patient is informed that he has a 5 to 10% chance of a recurrence. So one is operate when they are pushed all the way to the wall. So anyone can develop a recurrence. So the only thing is, if it is L5S1 versus L4-5, I would tell them the incidence make them happy. I would tell, you have L5S1, so the incidence of L5S1 herniation is less prone to recurrence compared to L4-5, which is statistically so in literature. So this is what the L5S1 patient feels happy about. Otherwise, everyone is open to this 5 to 10% rule.
Yeah, I completely agree. I think, the disc herniations are one of your worst patients if you really see all your patients and how much they cribble. So I think the best way is to tell them everything which can go wrong. And if you have already told them, you can, and no matter what you have done and how much you have tried, even if in best of your cases, you might have a recurrent disc herniation. It is almost impossible to predict which will go. So best thing is counseling, and that is one which really saves you, that I told you so.
Another last question before we move on, Guru, if permitted.
Yep.
So Arvind, Ayush, and Dr. Deepak and other Nepal friends. So when you receive a patient of recurrence, how do you break the news? Like a patient comes to you with post-op leg pain in 6 months, 9 months, 12 months. Be it your patient, is your counseling different from a recurrence of your colleague or your friend? I mean, how do you take it forward and start counseling? In a patient with post-op leg pain where you have documented that there is a recurrence, how do you break the news that the surgeon has left a fragment, it has recurred, or how do I deal with it? Arvind, start with you, then Ayush, and then my previous Nepal speaker.
Yes, so it is also the business of the other surgeon to have counseled the patient about recurrence. So sometimes it is news to me that he's been not counseled. So then you go back again and take responsibility of that particular surgeon and go start with the natural history again. And you, in the meantime, they start nodding their head, you tell it is natural progress and this and that. So by then you have captured them in your pocket. So
I think best way is to not to blame anyone. Either you are the primary surgeon or your friend is a primary surgeon. Just say ki this is what happens. Sometimes these things happen. And what I tell them is, you had, like, I always give them example of, like, the wheel of your car had a puncture earlier and it was repaired by me or by the surgeon. Now there is a second puncture and most likely the same side, and again it needs to be repaired. And as the wheel goes on, you might have a third puncture. That is how the life is and how the wheels goes around the life. So that is my way. And most of them, they sort of get convinced, and if it's my own case, most of the time I showed you, we almost record 90% of our case. That is how the system is. And we can tell them that, okay, see, this is what was done. And, we sort of removed everything, but this has happened. This is another puncture in your tire and it needs another repair. That's it.
Dr. Vinod?
Yes, I do agree with Ayush that it's best way is not to blame your colleague. the chances of recurrence is already been counseled, and I make sure that there is always a chances of recurrence by 15 to up to 25%, and the counseling is very, very important. And regarding the management of the desk, I'm very clear in my mind that unless and until the patient demonstrates the cauda equina syndrome, I don't ask them to go for the surgery. I want them to beg for the surgery, actually. I do to give a trial of everything non-operative measures, including the natural therapies, acupunctures, laser therapies, acupressures, everything. So once they beg for the surgery, then I start counseling to the patients regarding all the possible complications.
I think Prem had a question. Prem has raised his hand.
Prem,
Yeah.
that's last question, then we'll move on. Yeah.
Okay, sir. I have one small query. I agree with Dr. Binod sir also. So, does the size of the disc have any role in the recurrence of the disc or the type of disc, like protrusion, extrusion versus sequestration? So, what are your experience regarding the recurrence, different types of this disc?
So if you see, actually the literature says if you have a big annular rent in the first place, okay, so in the first place, so if you have a big disc which has caused a big disc annular rent, the chances of recurrence is high. And like the case I showed you, we removed quite a bit of disc, almost 4 big juicy fragments. And these are the cases, if you have done something like that, you might expect a higher recurrence rate because, the disc has a tendency to come out. There's a big rent, and if you have a big rent, it might lead to recurrence. And that is all we can say. And the literature at least is not very clear. And in my experience also, if it's extruded disc, normally the chance of recurrence is less, but it's a disc where you have to go inside the annulus and remove a quite bit of it. And if they are juicy with a big rent, I think they have a slightly higher recurrence risk, but it's very, very difficult to predict. That is at least my experience.
Okay, we are overrunning the time. So for the want of time, I thank Dr. Binod, President of ASSN, Dr. Arvind Kulkarni, Dr. Ayush Sharma for their nice talks. And we'll move on. The next will be case discussion by Dr. Gururaj S. And the panelists will be Dr. Binod, Dr. Ankur Nanda, and Dr. Rajesh Chaudhary. Over to you, Dr. Gaurav.
Thanks, Guru. I shall start to share my screen now. Okay, so at the outset, thank you very much to the ASSI and all the organizers for having us here as an association. So this is a 48 years female with right thigh shooting pain for the last 2 months, pain on standing and walking, relief on rest and sitting, no relief on conservative treatment and physiotherapies which were tried for 2 months. And now it has started affecting the quality of life, normal bowel and bladder. Examinations, bilateral SLR 90 degrees. The femoral nerve stress test is positive on the right side. The right thigh flexion, hip flexion is 4/5. Decreased sensation at L2 dermatome on the right side. However, no UMN signs. This is the plain X-rays, standing AP and lateral view. There seems to be a transitional vertebra at L5S1 region. And looking at the X-rays, except for a few degenerative changes, there is not much of finding. So I request the panelists also to have a look at the X-rays properly. And then can I move forward to the next imaging? Yeah, Guru.
Just a comment, Gaurav. So what we can see on the X-rays, there is a big osteophyte behind, if I may say. This is 1. If the last vertebra is L5, then this is 1, and you can see a big osteophyte along the posterior annulus. So this may easily be a calcified or an ossified disc, and I would keep a close watch at that while I assess my MRIs. Yeah.
Yeah, Ankur, that's what I wanted to bring out from you, whether there is anything or not. Thank you. Yeah. So if you see what Ankur has said, you need to look at this. The disc space also has decreased in L1, L2, and there is some calcifications posteriorly, also anterior to the thecal sac in the canal. So examinations, as Ankur has rightly pointed out, you can see there is a huge disc at the upper lumbar region, L1, L2. There is a huge disc, and also there is a massive lifting of the posterior longitudinal ligament. So any other observations from my panelist on these sagittal images?
Actually, already, as it is pointed out, whenever it is a higher lumbar disc, we have to be very careful. They are mostly calcified. Mostly there is a avulsion of an end plate with the disc. So we have to be careful in these two aspects, because if there is a major avulsion of the end plate, even if you do just discectomy, they don't get any relief. So we have to be very careful in that.
Okay.
I mean, other significant findings as such, we can see a big cyst in the sacral area, but mostly it's a Tarlov cyst. Usually they are asymptomatic and they don't trouble patients. So I don't think this would be something which is of importance here. Yeah.
Yeah, correct. So this is again a similar picture. There's a big disc in the recess and in the foramen entry foramen region at L1, L2, compressing on the right side on the axial images. Anything else, Ankur, Guru, Rajesh, Dr. Binod? That's it. Yeah.
Yeah.
Yeah, the clinical findings are exactly correlating with the imaging findings, So it looks like the disc is calcified at L1 and L2.
Okay. So basically it is it's the right side L1, L2 disc compressing on the recess and the foraminal region. And this is and since we have a less time of less than 10 minutes, let's concentrate on these few pertinent questions we have on this case scenario. So upper lumbar disc. So starting with you, Ankur, how common and maybe why do we see this upper lumbar disc very less when compared to the lower lumbar discs? So you may have been seeing these.
So we do see a fair number of upper lumbar discs, to be honest, but as compared to the lower lumbar disc, which is almost an epidemic in today's times, I think this number is quite small. Although since we are a tertiary referral center, we do have a sizable number of people who present with this. So they are quite different in management, because in terms of the pain patterns, in terms of the morbidity they can create, and if they are large in size, they can create a lot of weakness as well. And since the upper lumbar area has a bigger thecal sac and it's creeping more under the facets, so the management differs. I'm not sure how much you want to go into the detail of it, but yeah. So they are a different ball game as compared to the lower lumbar discs.
Okay, so maybe Dr. Binod, any red flag signs you want to point out in this case, whether the red flag signs are a little different from the lower lumbar discs?
Definitely, the upper lumbar discs are at the level of the chorda equina also. So conus medullaris. So the risk of having a chorda equina syndrome is definitely higher in the upper lumbar disc as compared to the lower lumbar discs.
Okay, so Rajesh, if you can come in, do you want a CT scan? So because Ankur and Guru have just pointed out that there may be an avulsion of the end plate, some bony fragments there. So do you want a CT scan?
Yeah, I think CT scan can help, like whether that is the hard disc or the soft disc, we can differentiate it from the CT scan. But before discussing more about this radiology, I would like to just point the difference of upper lumbar disc herniation from the lower. In case of upper lumbar disc herniation, I think most of the cases they present late, because in many cases the clinical features may not be correlating as we find in the lower lumbar discs. The canal is narrow, the many multiple nerve roots are compressed, so, and there may be features of conus medullaris syndrome. So the patient presents late, and as Dr. Ankur also highlighted, the management is also different. So I think, yeah, when I come to the question you asked, I think regarding the CT scan, I think CT scan will help whether to differentiate it from the hard discs or the soft discs and the size of the osteophyte itself. Yeah.
Okay, so before we go into the sequence of management, any other inputs from Guru, Ankur, or Ayush, or Dr.
So I think a little bit more on the CT scan part. So I usually get a lot of CT scans because I think it really helps in sometimes uncovering calcified discs which are not really there seen on the MRI. But in this particular case, I would think it's a soft herniation. If you see the disc prolapse, it is much lighter in color, although there is an avulsion probably of the end plate, but the disc is looking quite light gray in color. So the lighter the color of the disc herniation is, the lighter the likely it is to be fresh, and I'm less worried. The darker it is, the more jet black it is, then I'm more likely to get a CT done. Yeah.
Yeah. So can we go towards the next section, sequence of management? Yeah. Okay.
Sure.
Okay. So again, so coming back to you, Ankur, because we need to know how maybe you do it differently. What would be a sequence of management in these cases? In the upper lumbar disc, is it going to be different from the lower lumbar pathology?
So to be honest, I think the most important part for me would be to see if there are any deficits or not. And actually, I agree with Dr. Binod. I am very conservative with my management of discs. And if the patient is not, symptomatic in terms of a motor pathology, and if I have a migrated fragment like this, I may be quite tempted to wait. However, as you said that there is a weakness here wherein the hip flexion is grade 4. Now, grade 4 is, something in between. It may be because of the pain, and it may not be a real deficit. So if I am not convinced about the deficit, I may sort of, wait on. I may start them on steroids and reassess them in again 2 weeks, and then assess how they are going. And based on that, I would take a decision of whether we want to go ahead and operate, or we want to still hang on and, try nerve root blocks and things like that. So the basic principles remain the same, but my suspicion of going ahead with the surgery and watching out for the deficits is way higher.
Okay, so Dr. Binod and Dr. Rajesh, so the patient, now the pain is very severe. It has affected the quality of life, failure of conservative treatment. Okay, steroids also, it didn't work. And patient is begging for surgery. So what would be the surgical match steps, different options of surgery here you would want to offer?
In this particular case, if all the conservative measures has been exhausted, so in that particular case, the decompression is definitely indicated. But would you only decompress, or would you like to fuse in this particular case is the question. So considering the X-ray pictures and correlating with the MRI where there is the osteophytes, posterior osteophytes, that indicates that the progressive degeneration is going on. In that particular case, I would prefer going for the tele procedure, the interbody fusion procedures along with the decompression, if the surgery is indicated.
Rajesh and then Ankur. Yeah.
Yeah, I think in the upper lumbar disc herniation, since we also discussed the difference in the anatomy in the upper lumbar region, the size of the lamina is shorter. So when you are doing the laminectomy or decompress that canal, we tend to violate the facet and create the instability. So we should have the low threshold for fusion procedure, and while decompressing there should be wide channel to get to the neural structures, and we should not retract the neural structures much because we are around the conus medullaris area. So I think that's so as Dr. Binod also said, if we are violating the facets, then we should have the low threshold for fusion as well. There are different other approaches that has been discussed, like if there is central disc herniation, then transdural approach to remove the discs also, which I haven't done, and I haven't it's always scary to cut the dura by us. So I think but main aim is the adequate decompression, whether the hemilaminectomy or it is central disc herniation with bilateral symptoms, both the complete laminectomy, depending upon the instability assessed in intraoperatively fusion procedures. Yeah.
Gaurav, can I
Before you come in, Ankur, just before you come in.
Can you just put on the axial so that we can all see?
Okay.
And then you can continue. Yeah.
Yeah.
Please continue.
Yeah. So before we just wrap up this case discussion, before Ankur comes and tells us. So Ankur, so we know we need to decompress, we need to do something, and it is a high lumbar disc. Yeah. So there are some precautions to be taken, and so you need to highlight to us the precautions to be taken, the tips and tricks, whether to go for a posterolateral fusion or a TLIF.
Okay, so I think we have already probably zeroed down to the fusion in this case. I had just a comment upon, so this is also a nice case for a transforaminal discectomy, to be honest. This can be managed with that, because if you see that the disc is not really a very central herniation, it's more to one side. So transforaminally, it can be handled quite well. Also on the CT scan, I would like to assess if this osteophyte which was seen on the X-ray is more to the side where the herniation is, or is it more of a central osteophyte? Because many times these osteophytes are in the center, and if they are there, then it's not going to really hamper the surgical procedure. So that would be the disclaimer. As far as precautions are concerned, we have to be really, really careful, especially at the L1-2 level when it's an upper lumbar disc, because the resilience of the nerves to handle retraction is really low. It's not like the 4-5 and the 5S1. So we need to be really careful with the cord handling. Also, if you see here, the interpars distance or the facets are quite closely placed. The lamina is quite short. And this is a procedure where definitely I would like to do an interbody fusion rather than a posterolateral fusion. The reason being simple, it's a disc herniation. It's a large disc. There's going to be an in-plate defect. I will need to take down the facet while doing this. And once we are doing that, the preference is always to do a interbody rather than a posterolateral with the facet taken down.
Okay, so finally, so what I did was that again, so I did a laminectomy on the right side, did a thorough discectomy, but I did not do a interbody fusion. Went ahead and did a posterolateral fusion, and now it's around 5 years. This was after my fellowship. This was my first case. So L1, L2 disc. This was my first case. So this is very dear to me. So it's now been around 8 years down the line. No complaints till now.
Can I just add a comment, Gaurav, if you allow me 1 second?
Yeah, please. Endoscopy, guys. What would you do?
Yeah. So I used to do the same thing, exactly the same thing. Yeah. And once with transforaminal, it is the easiest thing you can do. What Ankur was telling, because it's a natural corridor. So if you understand, if you put the axial, just put it the axials. If you see the disc is going behind, okay, and your approach is such that disc is protecting your dura. Till you remove the disc, your dura won't come into the picture if you are going transforaminally. So that is the beauty. It will never come in your picture. Even if you go like slightly towards the canal, understand that point. The disc prolapse itself will protect you. It cannot be damaged till you have removed a good discectomy. So
Ayush, now what would you want to do? You want to do a endoscopy now, or you want to do open?
No, endoscopy, 100%. So I do exactly what you have done before.
Yeah, so I agree. I agree with Ayush. I think this is one of the best indications for transforaminal when you have such a lateral. So lateral herniation. So you can get away nicely.
Even you can take out the osteophyte. That is not a problem. So now, exactly after doing what you did, now we have all gone to transforaminal, not interlaminar. Interlaminar is very difficult for this. Transforaminal is the best way to do these cases.
Okay. Thank you, Gaurav. Thank you, all the panelists.
Nice case, Gaurav.
Thank you. So we'll move on. So the next case presentation will be by Dr. Rajesh Chaudhary, and the panelists will be Dr. Suraj, Dr. Arvind Kulkarni, Dr. Prem Sahi.
Is my slide visible, sir?
Yes, Rajesh.
Good morning, everyone. First of all, I'd like to thank ASSI for this ASSI and as well as the ASSN, the members who gave me opportunity to present the case in this forum. And my case is, I directly go to the cases. My case is 42 years old gentleman. He developed the right-sided radiculopathy 1 year back, which has worsened for 2 months. And now he has some back pain, but more of the leg pain, and VAS is 8/10, which is aggravated after prolonged sitting. Actually, he is a software engineer by occupation, and he works in Mumbai. He is Nepalese guy, but he works in Mumbai. The bowel bladder habit is normal. The epidural injection was given 3 months back, but there was not much of pain relief. He gives history of microdiscectomy done in Mumbai 10 years back. It was done in the L4, L5 right-sided microdiscectomy. On examination, HLRT is 60 degree on the right side and 90 degree on the left side. The neurology is EHL weak on the right side, impaired sensation L5 donometer, otherwise no significant findings. And this is the X-ray AP lateral and bending views. Here, I think we can see the there is some disc space, decrease in disc space at L4, L5 level, but no significant instability. Mild scoliosis on the AP view, but not that significant. So, and this is the MRI at present, and this the MRI, you can see the discs at the L4, L5, and this is the T1 weighted image, and this is the axial section. Here we can see the discs on the more central and right paracentral region. And this is again the T1 weighted image. Now I will come to the panelist, and Dr. Arvind, how will you manage this case? The patient has basically he has the symptoms that is affecting his occupation. He is not able to do his work properly.
Rajesh, can you just put up the MRI slides and while Arvind talks? Yeah. Dr. Arvind, are you there?
Yeah, I think if Dr. Arvind is not there, then Dr. Suraj, you can just add something.
Okay.
Dr. Arvind has
Yeah, he's there. Yeah, Arvind, please go ahead, and then Dr. Suraj probably.
So if I know it right, he has leg pain or back pain now?
He has more of the leg pain, but mild back pain also. But more of the leg pains.
He's a young patient, heavy manual laborer, right?
No, he's a software engineer. He has to work like
he still has a high demand back, and there is stenosis, associated disc degeneration. I would do a TLIF in this particular patient, a minimally invasive TLIF.
Okay. Do you differ, Dr. Suraj? Do you have any difference of opinion?
I think surely the patient has symptomatic things. One, there is no neurological, and it seems to be recurrent because it has had 1 year back surgery. We have to counsel the activity of the patient first, and whether you tried a conservative management again for the second attempt for the surgical approach. If then patient convinced, then we can go for the minimal invasive surgeries, I think. But beforehand, I would like to suggest for the conservative management, as it has already been intervened previously.
Okay. So any role of endoscopic discectomy only or non-fusion surgery here?
I think non-fusion surgery will be adequate.
So you don't want to go for the TLIP?
I don't think so. It is a very young man. I think it is suffice.
Okay. Dr. Arvind, can you just elaborate on why you want to do TLIP in this case? A few salient features that you see in X-ray and MRI.
No, I'm not saying decompression is bad or shouldn't be done. So TLIF encompasses everything. It encompasses what you look for future, look into his future. He has a degenerated L4, L5 disc. There is some degree of instability also there in terms of, I think it's collapsing on flexion extension. And I forecast that this patient might come with, symptoms of back pain or recurrent symptoms later on in life. So he has a high demand back. These people sit for 8 to 10 hours every day. So for the current level and for the current moment, I would be happy to give him patient would be more happy with the TLIF procedure rather than a decompression procedure.
Okay. Thank you, sir. I also thought the same way, and I performed the TLEAF in this case. This is the intraoperative CM pictures. The this is the immediate post of X-ray. But immediately after the patient is out of anesthesia, he developed radiculopathy on the other side, the left side. So, Prem, what may be the cause of radiculopathy on the other side? Like in this case, I approached on the right side. I didn't do anything on the left side. As we all think that there will be indirect decompression on the other side if the foramens are opened. So what may be the different causes of the radiculopathy in this case?
One is your screw position is a suspect. If you show the screws, the inferior screws, they look quite inferior, especially. I don't know which side did you go from?
Right side.
So the AP, can you go to the AP? Is your right and left?
Yeah, the right is right, sir, because there is the black part is the pusher, that the rod push. I mean the case pusher. So the right side is right.
So it was a L5 dermatomal pain post-operative.
Yeah.
So you didn't decompress the opposite root?
No.
So can you go back to the MRI axial films? Actually, the lateral recess on the left side is quite open, quite free.
Yeah.
See, some patients, they do develop neuropraxia. It might last for a few days, sometimes extending from 3 weeks to 3 months. Did you give it some time to resolve?
Yes, sir. Then I just, in that case, I just counsel the patient. Maybe it can be due to retraction of the root. So I immediately started the steroid, IV steroid. And after 7 days, he has some relief. And then I continued it. He had some pain relief. And this was the X-ray after 1 month. There was some evidence of case back out on the right side, but the patient still has pain on the left side. So how to proceed at this stage?
Did you give a block?
It's absolutely okay on the right side. All the symptoms are on the left side.
A block on the left side?
Yeah, that's what I thought. Yeah, that's what I thought. And then I repeat the MRI, whether there is something causing the root compression on the other side. Maybe while pushing the graft, maybe pushing the case, the graft may have compressed around nerve root, or maybe there was already stenosis that is more aggravated. So I repeated the MRI and there are no significant compression. So I did the transforaminal epidural injection in this case. So I would like to generate the discussion when earliest when we can do the put the epidural injection in the post-operative cases. Like, should we wait for 1 month, or what is the time frame the earliest we can put the epidural injection?
I don't think we are bound by time. You see, initially you will not, first day anyway, if the patient comes, you will not suggest epidural. Usually give it some time, you'll try oral medication, gabapentin and all that for some time to, you expect it to get better, with time. With some kind of, suspecting that there is some nerve root edema, etc., traction and all that. So if it doesn't resolve, so by the time that happens, it will be about 15-20 days. So, full 15-20 days you can give before you decide on an epidural or a block. It's a very empirical thing.
Yeah. And in this case, immediately after giving this block, patient has significant pain relief and the patient improved significantly. But what was that, like the case back out preventable? What were the possible causes of case back out in this case?
Yeah, there is a significant back out of the...
I think your cage was smaller in size to start with. If you see the intra-op images also, and it was not so far anterior right from the beginning.
Yeah, I also think so because I put the 9mm size case, and it was I usually do not compress the compress after putting the case. Now I have started putting compressing, but usually I used to just put the case and see whether it is snugly fit or not. So I think that's the important point, the proper size case. Yeah.
And the nature of this segment, if you see the MRI and X-rays, is kyphotic. This particular segment is kyphotic. So unless you hammer in your cage quite anteriorly, and unless you put a lordotic cage, so there is a, the vectors are in favor of kyphosis, which can push the cage backwards.
All right.
Okay, and, yeah, this is the X-ray 1 year post-op follow-up, and the patient is completely fine, and there is no radiculopathy on the either side now. So I think this completes my case presentation. Just to highlight the point that while in the recurrent discs, if we can perform the TLIF, and if we are decompressing on the one side, there may be stenosis on the other side. We should be careful of that, and sometimes we may get the unexpected outcomes like the contralateral radiculopathy, but we should be more conservative, and sometimes the conservative management gives a good result. Thank you.
Okay, so thanks, Rajesh. It was a fantastic case, and thanks, Gaurav. Also, both were fantastic cases. So we'll quickly move on to the second part of the session, and go through some talks. So the next presentation is by Dr. Gururaj, and he's talking on large disc herniations. When is the fusion indicated? Guru, can we have your slides, please?
Yeah, can you see my slides?
Yeah.
Okay, so all this while we spoke about conservative treatment and only discectomies. So let me be the butcher here. So where we talk about what not to miss and not to have a very unhappy patients, and everybody cannot have that 7 Kuhn maaf. So you can do 2 Kuhns, 3 Kuhns, but then yes, ultimately you might have get some punishment for that. So let's not miss certain things. When fusion is indicated, we have to do the fusion there. Okay, so there are multiple options, especially whenever it comes to a disc, and especially when it comes to a large discs like this. So that's why there is a lot of confusion prevails whether to do just a discectomy, whether to do a fusion. And most of the times we all end up doing, including myself, we all end up doing a simple tubular or an endoscopic discectomy here. And most of these patients do well. But then sometimes we just get caught, and we have complications, or we have to do a repeated surgeries on these patients. So let's see when to not to miss these points, and when go ahead and do a fusion. So that's again a big disc, and so there's no instability, especially there's no instability. Again, we are confused whether to fuse or not. Let's see what happens. So we all get caught in this keyhole. We don't see the bigger picture of these large disc herniations. We just end up seeing the disc and doing discectomies and end up having problems. So what are the things which are associated? What is the bigger picture of these large disc herniations? So a large disc herniation is defined as whenever the disc occupies more than 50% of the canal in the MR axial cuts, it's called as a large disc or a massive disc prolapse. So we all want to do surgeries and have happy patients like this. And for that, we have to do whatever it takes, whether it takes just a discectomy or whether it takes to do a fusion. So usually these kind of massive discs happen in a manual labor who have a high demand back. And if we do just a discectomy in them, their back pain might continue to happen, and they might not be able to pursue their manual labor job. And they happen due to traction. There is a part of end plate which avulses with these large disc herniations most commonly. And especially in those patients who have a hypermobility, or you have a hypermobility after having a massive disc prolapse. So vice versa. So then again, it's a tricky situation just to do a discectomy. And it happens in a productive age group at 40 to 50, where you have a high demand back. And especially in obese people, where BMI is more than 25, again, doing just a discectomy is a tricky situation in those. And usually these discs are central, where you need to do a lot of decompression. And to take out this central portion, you need to go more from laterally and go into the center. And usually they are migrated up and down and calcified, or they have a part of end plate avulse with them. They have a big annular incompetence. That's what we discussed during the recurrent disc session with Dr. Ayush, that they have a big annular rent. So that's why they have a big annular incompetence. And usually they are stuck to the thecal sac. Sometimes they can be intradural. There can be foraminal extension, and sometimes they are bilateral. That means they have a bilateral radiculopathy symptoms. As we were discussing, there is a avulsion from the end plates, end plate defects, and a lot of times you see that particular segment with a large disc herniation is kyphotic, and it compromises the sagittal balance of the lower lumbar spine. So what we commonly miss is this, that is 60% of these large discs have an end plate failure. So when you do just a discectomy in these patients, they continue to have a back pain. And they do have an instability. What we tend to miss is, we just do a flexion extension x-rays. But in this large disc herniation, more than an angular instability, they have a vertical instability. What do we mean by vertical instability is, you do an x-ray in supine position and do an x-ray in standing position, you will see the disc height is reducing. So that is what is a vertical instability. So most of these patients have a vertical instability, and we need to investigate for that. And as we discussed, there can be calcification and intradural ray. So that's the publication which we had, Ayush and myself. And you can see that's for the intradural disc, and had to be removed after doing a urotomy. And if you see this huge disc at L4-5 and see the calcification, in this case, just to do a discectomy, and when this particular thing is adhered to a dura, is really, really a challenging. If you try to do just to do a discectomy, you will do an inadequate job, and you will not have a happy patient. And in terms of symptomatology, these patients have a severe hyperalgesia, and usually they present with bilateral symptoms. You might have to go and do a discectomy from both sides. In doing so, you create more annular rents, more annular incompetency, more iatrogenic instability, and ultimately these patients end up having a repeated surgeries. And most commonly, these patients present with weakness, especially cauda equina and foot drops. If at all you have a major significant neurological deficits, if you retract these nerve roots much more to remove the offending disc, then you might end up having neurological worsening. So you might have to go ahead and from laterally go medially and cut more bone. So again, it might need a fusion surgery. And most of these patients do present with severe back pain, and cauda equina syndrome is as high as 45 to 60% in these patients. What is the problem statement? We all know that with the large disc prolapse, there can be a collapse in the disc space. That's what I was mentioning. There's a vertical instability. It can happen at the index time, or it can happen after you do a discectomy. And it causes a reduced foraminal height. And coming days, you develop a foraminal root compression and persistent discogenic back pain, or ultimately you can have a persistent radiculopathy. So you need to restore the disc height. So for that, you might need to do a fusion. And again, a large disc collapse of the disc space, it can cause a degenerative listhesis with or without instability. That might cause, again, claudicant symptoms or a radiculopathy because of foraminal compromise. Again, you might have to consider doing a fusion surgery for this. And as I was mentioning, these patients usually present with severe back pain. If we don't take care of it, or we don't look for it, then we can have a residual or a recurrent back pain. As we discussed already this. So there is this unholy alliance of large disc with these few things we have to understand. That is obesity, elderly age. They usually present with facet tropism and modic changes. which make your patients unhappy if you just do a discectomy. In terms of technical challenges, we have to do a wide decompression, which can cause a iatrogenic instability. A nerve root retraction, if you have to do, it can cause a traction injury to the nerve. So avoid retracting the nerve roots over and above the offending disc, and which causes more traction onto them. It causes more of a dorsal root ganglion irritation. And because these are mostly stuck or calcified, or it's a huge disc, there can be incidental dural tears. So to avoid that, again, we might have to do a wider decompression, and pre-existing neurodeficits again prevent us from retracting these nerve roots. Also, we have to consider the occupation, education level of the patient, how much they are able to understand. All patients will not be ready like Ayush, that they will undergo one discectomy and they will come back for another discectomy. If that fails, again come back for a fusion. So we have to discuss with them in detail what is the expectation of the patient. That's why communication is very important. High demand jobs, again, the fusion is better than just doing a discectomy in these patients. If they can't modify their activities, they cannot suit their work to back, again, you need to give them a stronger back and Indian households. So shared decision is very, very important. Few cases, you see there's a massive disc, just did a T-leaf there, and then again one more case, and that was again managed with the T-leaf. So take home message, there can be disc space collapse, look for that. There can be listhesis, vertical instability, foraminal stenosis, and there can be a persistent discogenic back pain. So when you do surgery for this, try not to cause iatrogenic instabilities, try not to cause traction injuries to the roots, DRG irritation, and surgeon-induced cauda equina. So if at all you feel that you have to retract more nerve roots and cause worsening of the neurological deficits, it is better to fuse. So don't get caught your pants down. In these patients, look for the bigger picture, and fusion is worthwhile in these patients. Thank you.
Thanks, Gururaj. It was a nice talk. So we'll quickly move on to the next talk and then take the questions after we finish the session. So it's a pleasure to invite Dr. Suraj Bajracha, who's the Secretary of the Association of Spine Surgeons of Nepal. And he's speaking on approach to a patient with post-discectomy discitis. So yeah, over to you, Suraj. Please share your slides.
Good morning, all. Is it visible?
Yes, it's visible. Yeah.
Okay. So first and foremost, I would like to thank ASSI for giving this opportunity. Our whole team of ASSN is present here, contributing the ASSICon 2024 to be held in Mumbai. Best wishes for the successful completion of the ASSICon 2024. It's been 1 month that Dr. Guru and Dr. Ankur has been asking for this session, and now we are having this going on successfully. First and foremost, I would like to thank all present faculties. So this is now the one of the very much important topic. Once we have discussion in different topics of disc disease, one of the nightmare for the surgeon and one of the dreadful complication for the patients to have. So this word,
Suraj, can you put on slideshow, please? Can you go on a slideshow? Yeah.
Post-operative discectomy has been a clinical entity in 1953 since then by Frank Turnbull, and it is an infection of the nucleus pulposus and secondary involvement in all other part of the discs. So this is a very important that we do surgeries, we find technically, but once we go into these grave consequences, is really coming back is very difficult, and we pray for the God at once happen. So in my lifetime, there is 2 or 3 cases have been encountered, and this incidence is very low, even though 0.2% to 4%, and it is mainly due to instrumented or non-instrumented fusions or discectomy as well. One of the most important clinical symptoms that we have is constant back pain, even after the even in the night, even after the surgery. Once the surgery is done, that we find that there is no radiculopathy, no pain, but these are the dreadful things that we come with the discitis. And so the presentation may be starting from 1 to 6 weeks, and the only thing that we have is the high index of suspicions, and from that one only the treatment starts. So that's why we need to have a high index of suspicion in case of any signs of symptoms of infection or inflammation in the body. So the dreadful things is that the extensive involvement of the infection to control beforehand. So the high index of suspicion is very important in deal with. So we can divide in classification of spinal infection in depends upon the location of infection between the bone, discs, or paradiscal regions. So usually the discs, when we find the post-discectomy, it can even affect other part of the part of the vertebra and the ascending the things, the spinal abscess, discitis only, or spondylitis, or paraspinal infection leading to intramedullary abscess, subdural empyema, epidural abscess empyema, spondylodiscitis. These are the very extended forms of discitis, and this infection is very important to classify by Thalkot being infected by different organism. And organism is very important in the case of post-discectomy, post-infection, post-discitis, post-surgery discitis. So now risk factors, most of the things that non-influential that we have to consider beforehand surgery is advanced patient age, ASI, higher ASI scoring, obesity, diabetes mellitus, substance abuse, chronic infections, long-term steroid use of the patient, poor nutritional status, and immunological incompetence should be considered beforehand that we have to encounter. We can encounter this later on. So the most important non-influential factors is type of surgery that we are dealing with, long duration of the surgery, blood loss during surgery, type of instrumentations, and quality of the operations like evasion, multiple interventions, and significant risk factor leading to surgical infection rate is 1 to 4 after spinal surgery. So most important factors while considering the surgery, we need to know about the patient's build. That is, subcutaneous fat thickness more than 50 mm is significantly high risk of post-operative infection and colonization by the microorganism. So this factor is very important in considering the infection that we do in surgeries. So microbiology is very important, that most of the infection is by bacteria, followed by fungi, and also by parasites, which we have to consider. So there are the ranges and microbiological microbiological agent that we need to consider in case of infection, like Staph coagulase negative Staph aureus, E. coli, fungal infection like Aspergillosis, Candida, and Cryptococcus neoformans. And at times we have to make a differential diagnosis of this type of fungal infection too while searching the cause. So diagnosis, due to the low specificity of the signs and delay in the diagnosis, remains an important issue. So therefore, the diagnostic tools and procedure have improved. And even though they are improved, the delay in diagnosis is very one of the hindrance factors for the treatment. So the laboratory parameters we have to consider, like CRP. I would like to consider that CRP is one of the most important things that we need to do. That is 90% of the acute spondylodiscitis is a sensitive marker. ESR is also a sensitive marker for the infection and still increase 50% of patient in good clinical outcome. So WBC, it is non-specific. Procalcitonin is very important promising factor in the bacterial and non-bacterial infection, and it's very difficult, low sensitivity than the CRP. But if there is a multiple infection site, that procalcitonin is very important to consider. So blood culture is one of the most important things, that blood and the urine cultures should be collected, and empirical antibiotic therapy should be done beforehand. And 59% of the positive blood culture identify the etiological microorganisms. So biopsy is one of the gold standard, more so by the CT guided biopsy. If you suspect that there is considered to be infected tissues, the imaging, one of the most important reliable method is MRI, which is highly sensitive and highly specific, 96% and 94% respectively. So we need to know the infection of high intense discs in vertebral bodies in T1 and hyperintense signals in T2. So these are some of the, I would like to consider that we have to go MRI if you suspect in. Later on the CT, the X-ray, it more so one of the things that the later part of the infection can be seen, but early detection is very low in case of X-ray. So in X-ray, it takes around 7 to 10 days to show the features like some changes in the interdiscal or peridiscal regions. So the CT scan is more so for the biopsy purpose. So we can use CT guided biopsies to get the specimen for the culture and the stains, and CT biopsy is directed towards the site. So nucleotide isotope scans are very important in finding the cause of the infections, mainly the gadolinium imagings and also the fluoro-2-deoxy glucose. So the flowchart for the clinical suspicion of spinal infection goes with the blood and the radiological investigations. If there is a positive MRI, confirmed spinal infections, it gives the etiological diagnosis. If there is a negative conclusion of MRI, the nucleotide imaging, and then it can be positive, it confirmed, and negative, then we can say that there is no spinal infection at all. But at times it is difficult to say that bacterial rather than fungal may not be found in such cases. So another etiological diagnosis once you get, whether it is neurological condition, spinal instability, or sepsis, and if these two things gives the guidance for the surgery or not to do conservative management or not. This flowchart is very important in getting into the diagnosis. So principle of the disc treatment is management can be optimized by early diagnosis and rigorous evaluation of the severity of infection, whether disc is involved, whether the breach of the or the component of the meninges is involvement, or there is a neurological compression is very important in the process of doing so. So the treatment depends upon the type of infection and the immunological, neurological, and clinical status of the patient. So when prescribing the antibiotic, is necessary to know the source of infection. As soon as the surgery is deemed, empirical antibiotics must. Combination of the antibiotics is must. There should be combined antibiotic with both aerobic and non-aerobic, and other antibiotics should be given. And we have to obtain the high plasma concentration in the blood to conquer the infection at the site and further septicemia or further complications. So the medical therapy, some author advocates 6 to 8 of intravenous therapy alone, and some proposes 6 to 8 intravenous antibiotic followed by 2 months of oral therapy. So the intense therapy is must, and along with the strict bed rest, giving the psychological support, giving the counseling is a very much. Unfortunately, there are a lot of study has been done, but randomized studies or sufficient data in literature to compare conservative management versus surgical management is very, very poor. So the option of the treatments depends upon either conservative or operative, but still now there is no established validated protocol for treatment of the post-operative lumbar discitis. So this is one of the gray area that we have to deal on it. Although the mainstay of discitis treatment is combination of bed rest and prolonged administration of antibiotics, to some of the advocate, the duration of the antibiotic is very much controversial in case of infection of the discs. Thus, the surgical intervention is occasionally necessary for patient with falling conservative treatment, that is neurological condition and the excruciating pain not relieved by the opioid analgesic too. So there is another controversy around whether to do early or delayed debridement of the site of the infection is one of the controversial thing. Using the graft, using the implants is also another one of the gray and controversial things in the treatment of post-discitis, post-operative discitis. So the management depends on different presentation. Like if there are other components, then we have to give extensive treatment and debridement and multiple level fixation and fusion. So there are many, very much other options, like whether we have to go minimal invasive, endoscopic, percutaneous, decompression and degradement plus instrumentation, discectomy, further discectomy, corpectomy plus instrumentation, or complex anterior posterior reconstruction plus instrumentation, depends upon the extent of the infection that occur and the time of diagnosis of the infection. So the operative treatment depends upon different type of affection that we have encountered. So depends upon the decompressions, debridements to drainage to corpectomy to anterior and posterior fuses, depends upon the extensive nature of the post-operative discectomy. So this is one of the very much controversial topic that we are dealing with. When then, if encountered, then we have to search for the literature, and literature also is not so supportive. So lastly, take home message where I say that the symptomatology we have to treat conservatively. It's very excruciating pain. Even the non-opiate and opiate analgesics are not adequate. The tissue biopsy and the microbiology very important in targeted treatment of the discitis, and instability we have to consider, and neurology. This 4 component is very important in the management of the post-operative discectomy. Thank you very much, and I'd like to invite you all in next conference of Himalayan Spine Symposium on 15 to 16 November 2024, which is will in the eastern part of the Nepal. Thank you very much.
Thank you, Suraj. It was a very wonderful and elaborative talk. So next, moving on to the next talk, I would like to invite Dr. Ankur Nanda. He's going to talk on upper lumbar disc decision making. Over to you, Dr. Ankur. Dr. Suraj, you have to stop sharing your screen.
Yes. Where have you?
Yeah, thanks, Guru. And I think my job has been made a little bit easier because Gaurav had presented a case on upper lumbar disc just in the first half of the session, and so some of the points were clarified. But so can you all see my slides?
Yes,
Guru,
yes, we can.
Yeah, okay, all right. So upper lumbar disc, how is it different? What is the whole discussion about? So the main point why we are discussing this topic as separate is, as we had discussed it shortly previously, the anatomy of the lower lumbar spine and the upper lumbar spine is very different, and the difference lies in this, not only in the smaller canal diameter which is there, but also a larger dural sac which is usually there at the upper lumbar levels like L1-2 and L2-3. And what it means for a surgeon like us is that the nerve roots are usually well within the border of the lamina in the lower lumbar spine. However, in the upper lumbar spine, the nerve roots are sort of hidden under the facet. So in the upper lumbar spine, in the lower lumbar spine, you can go ahead and do a MED or a microendoscopic discectomy, and you can easily visualize the lateral border of the root. However, in the upper lumbar spine, because the nerve roots are hidden under the middle margin of the facet joint, so it's a little difficult to access these nerve roots. And when you try to do a MED or a decompression, there's a lot of facet joint you have to cut, and you may end up creating a little bit of instability or more instability depending on how much the bone is being cut. However, if the same scenario is seen in a lower lumbar spine or in an upper lumbar spine, when you are trying to do maybe a midline approach, then probably you can take off the midline structures, and you can do a funnel shade approach wherein you can access the nerve root. So you need to sort of understand the anatomy before you decide which approach you're going to take. However, again, in the if you look at the transforaminal endoscopic discectomy, we know that for a transforaminal approach, usually the scope is docked in the medial pedicular line, and the approach to the disc is a little shallow. However, on the upper lumbar area, the transforaminal approach is more steep, and the docking is done usually at the mid pedicular line, and the approach is a little steep. So when you have a central large disc herniation, it is quite amenable by the transforaminal approach for a central herniation. But in the upper lumbar area, because the approach is more steep, a central herniation may be more difficult to tackle. So we need to understand these differences in the anatomy before we start taking decisions on what approach should be taken for an upper lumbar disc. Also, we know that the disc spaces, they lie approximately at the same level of the interlaminar space in the lower lumbar spine. On the other hand, the disc spaces are a little more cephaloid in relation to the interlaminar space in the upper lumbar spine, and so a more amount of bone is needed to be resected, which can potentially create more instability. So we have to understand that there are multiple factors which affect what sort of surgery we want to take. And, as we saw in Gaurav's case, we discussed from, discectomies to fusion to even transforaminal discectomies. So what are these factors? So one of these main factors would be the size of the disc along with its location. whether it has migrated up, migrated down. Is there any associated calcification or ossification? How much is the spinal cord deformed? What is the distance between the two parts? How much is the space available? What is the medical condition of the patient? And I think at the end of the day, also the surgeon experience and expertise in handling different modalities. So this was a paper which was published by a group of surgeons who were evaluating their own transforaminal percutaneous endoscopic lumbar discectomies. And what they found out that they had excellent outcomes in herniations which were posterolateral in 61% of the cases. But in herniations which were central, their excellent outcomes were only seen in 15%. And what they gave was that the predictive probability of an excellent outcome was only 4.6% in a central disc herniation at the upper lumbar spine. So we have to understand this. And there have been multiple papers which have talked about individualizing the approach. Like this paper, it talked about each herniated disc nature should be assessed before taking a decision on what surgery needs to be done. And looking at this paper also, it talks about individualizing the approaches. So I've put down a few cases just to look at what sort of approaches we can take for upper lumbar disc. So this is a small this is a male 34. He's got a small disc herniation at the L2 L3 inferior migrated level, and it has traveled down a little bit to the left side. And for this, what we had done was, because the patient had a lot of pain, we had done a normal tubular discectomy operated from the left side. And the reasons for taking this approach was very simple. It was a lateral herniation going into the foramen. It had a wider distance between the pars interarticularis, and there were non-vertical facets. So we knew that the facet compromise would not be so much, and such a disc herniation can be easily dealt by taking off from the MED approach. Another patient, this was a 22-year-old male, and he had a central disc herniation. And these are the axials, and you can see the patient had bilateral radiculopathy. And for this patient, we had taken an open approach, wherein we had gone ahead and done a surgery wherein we did a funnel technique, and we could approach both the sides lateral nerve roots. And since this was a central disc, soft herniation, bilateral symptoms, and the distance was narrow, so we thought that an MED may be difficult to do in this patient. Now we move on to another case. Now here the patient is much older, 74-year-old, severe bilateral leg pain with left-sided weakness. And if you see in the dynamic X-rays, we can see some amount of angular instability happening. The anterior lips are touching each other. So this is at the level of lumbar second and lumbar third. This is how the MRI of the patient looked like, similar to, I think, so you can see the central disc herniation here at L2-3, and which is then going on towards the left side and occupying the area near the pedicle as well as it moves upwards. So this patient was operated for a lumbar second and third TLIF with the bilateral L4 L5 laminoforaminectomy. And the reason we chose TLIF here was it was a large disc. There was a significant upward migration. There was a pre-op angular hypermobility, and there were neurodeficits. And probably the patient was older as well so we could afford a fusion. So this is why the fusion was done in this case. Another case, 73 male, he had severe leg pain with claudication, no back pain, and no instabilities as seen on the X-rays. Now this patient had now a large inferior migrated PIVD, L2, L3, and this was mainly towards the left side. So what we did in this case was, we did a L2-3 discectomy with left hemilaminectomy with a quadrant mass retractor system, and we did not go ahead and do a fusion here because we thought that the fragment would be, feasible to be taken out. Patient had only one-sided symptoms, no deficits. This was the immediate post-op, and you can see these staplers showing the incision on the left side. And this is his X-ray post-op around 6 months later, showing no instability, which has creeped in this time. So a quadrant discectomy, because it was a unilateral symptom, soft disc, there was a good space available between the pars. There was no pre-op instability. Another case, 56-year-old female, bilateral lower limb paraparesis. So she had multiple nerve roots involvement, severe pain in the leg, and this is how her MRIs look like. This is how her X-rays look like. And if you see on the X-ray, there's ossified shadow seen behind the L2 vertebral body. So we went and got a CT scan done, and we saw a large calcified disc which was there behind the L2 vertebral body. And for this patient didn't have much significant back pain. So for what we have done is a large wide decompression, because it was an ossified disc. We didn't want to touch the disc on the front, so we just did a wide decompression, got the facets out, and fixed her up, along with decompressing the roots on both sides. So the take-home message is, if you have a central soft herniation, bilateral symptoms, narrow distance between the pars, probably an open discectomy with a midline exposure, and having a funnel approach may do the trick. However, if you have a lateral or a foraminal herniation with a wide distance between the pars, intra-articularis, and non-vertical facets, either an MED or maybe better, a transforaminal endoscopic disc herniation, endoscopic discectomy can be done. On the other hand, if you have a large disc which is calcified, which is significantly migrated with a pre-op instability and neurodeficits, maybe fusion will be a better bet.
Okay. Thank you, Ankur. That was a wonderful presentation. So this session is open for discussion now. If you have any...
Yeah, if I can ask Guru. So you spoke on fusing these people with large discs, but in more often than not, we come across scenarios wherein patient has come with a large disc, he's got severe radiculopathy, and he has no back pain. So do you feel confused at that time, whether you want to fuse or not? Because that, once we go ahead and do our fusions, they do tend to develop some stiffness, some pain in the back. So ultimately you end up in a scenario where you have taken away one pain and given a new pain to the patient. So what are your thoughts on that?
Okay, so the gist of the topic was, if you have to do a fusion in all cases, it's no brainer. But then if you have to do a discectomy, then whatever factors I mentioned, you need to look for them. Whether there is any instability, whether there is any calcification, whether there is any pre-existing deficits. So if none of them are there, you can safely go ahead and try to do just a discectomy without doing a fusion. That's what I said. Most of the times we end up doing just discectomies, but we have to keep our brains open and see a bigger picture of a large, massive disc and rule out all other factors. If you have a moderate to mild disc on a paracentral area, you can just straight away go ahead and do a discectomy and come.
No, so Guru, so please don't get me wrong. So my question was, you have an ideal case scenario for doing a fusion. So let's say you have a large calcified disc, but patient has no back pain, and now the patient is going to get some stiffness. So how do you counsel that patient, and how do you explain that?
We need to be very sincere to our patients and tell them that the neurology takes the precedence over anything else. So whenever you want to give them it's a quality of life surgery. So if you think that his leg pain symptoms are much more and his weakness is much more worthwhile than that mild stiffness or a mild back pain which you are going to give after the fusion surgery, you can go ahead and do it. And you have to be very sincere with your patient and tell them that your leg takes precedence over your back. And after I do surgery, you're going to have this new pain. But then most of the times we have seen this pain remains for 6 months and a year time, and then slowly it settles with a good rehab program in the post-operative period.
I have one comment, Ankur. I have one comment to add. So basically, it is slightly other way around. For central disc, for lower lumbar, it is much more difficult to go because the interlaminar distance is much. So if you're going like this, you might end up, it's very difficult unless you take a bit of facet out. But as you go up, the interlaminar distance becomes shorter. So central disc at L1, L2, D2, L1 are much more easy to approach if you are using a 25-degree scope. So that is how it is. So if you want to do a central disc,
so you are talking about interlaminar or transforaminal?
Transforaminal, not interlaminar, transforaminal.
So you mean to say the transforaminal is more easier to do in an upper lumbar disc to the central?
Exactly, any given time, because your interlaminar distance is short. So this is your interlaminar distance. You want to reach here. You will tend go here. But imagine this goes shorter. You will reach much more. So you can do a central disc much more easily for an upper lumbar level through a transforaminal approach. That is how.
So that's interesting, Ayush. So I don't do transforaminals, but then the papers I was quoting, these papers were published from Korea. I think a case series of around 1600 cases, and these animations are taken from those papers only, wherein they explain why they had difficulty in the central herniations and why they had inferior results. But it's an interesting take, I think, and
Because
probably
if you ask me,
yeah.
because we discussed this with the endoscopy guys, and everyone will say if they have to do a central higher lumbar, they'll go transforaminal, and maybe the scopes have changed. It is better. You have better optics, and the angle is important. You need to use a 25-degree scope, so you can see more. So that is the whole idea. If you can see more with the flexible pro, it's just about taking out the disc. That is our experience as a
yeah. Satyan, you wanted to say something?
Yeah, actually, I have come across a couple of cases where transforaminal discectomies have been performed in higher lumbar disc herniations, L1-2, L1-2 mostly, and both two patients we've seen who have come with neurodeficit post-operatively. Is it something which is of a concern that there is a chance that you can actually go into the cord because of that angle, or is that just a learning curve?
It is very difficult to do that. It is the other way around. So disc is pushing your cord back. You to damage the disc cord in higher lumbar with the transforaminal is you have to be very, very good at it. That is what if you're a bad surgeon like me, you will end up on disc because sort of disc is pushing your cord back and it's protecting you until only way you will land is on a disc. So you want to damage the cord with that? That is a tricky game. At least that is how I see it.
Okay.
Sure.
Okay.
So, Dr. Suraj, if I can ask you, we were talking about post-operative infections and management. But then, many a times you get a patient who comes into your OPD and, he's just having some wound discharge, not so much. And you are confused whether you want to start him on antibiotics or you want to go ahead and aggressively treat it. So what is your take on this? How do you decide which ones you want to immediately debride and which ones you want to hang on and give antibiotics? Any comments on this, Dr. Suraj?
I think Ankur, he is left.
Achha, he's already left, is it? Okay, I think then we'll... are they... Yeah, Guru, you wanted to say something?
No. I said he has just left.
Okay.
I think Satyan can answer this question.
Yeah, it's a very difficult situation actually, this post-operative discitis, and these patients are often very unhappy. So I actually, most of the time I try to treat them with IV antibiotics only and see how they go. But if they are, it's more about more than the response radiologically or through biochemical markers, it is more about the patient complaints. And if they are too much in pain and complaining too much and just not happy, then I faster than usual. So it depends on how the patient is responding. So I have a lower threshold to fuse them and get in early, but of course IV antibiotics need to be started. Having said that, these are very, very difficult cases and it's a bad complication. Infection is our worst enemy here.
Yeah, I think we should move ahead.
Okay, so if there are no more questions, we'll quickly move on to the case discussions. So the next case is going to be presented by Dr. Satyan Mehta. Satyan, please go ahead and share your slides and let's see what he's presenting.
And Satyan, I think Dr. Ketan is here. You can involve Dr. Ketan also in the discussions.
Sure.
Yep.
So you guys can see my screen, right?
Yeah.
Yeah. So this patient is a 38-year-old male. He had a discectomy done at L4-5 level about a year ago. After that, he was okay for some time and then again started getting back pain and right L5 radiculopathy since about 3 months. Managed non-operatively, but he did not get much improvement. He also started getting weakness in his right L5 for about 3/5 was his weakness. But basically, he's mainly complaining of radicular pain. So this is what the MRI showed. I've straight away gone to the MRI, and this is the stage that we are at here. Ketan sir, if you're there, can you just give me an idea about what you're seeing and what we should?
Yeah. So it is the I can see there is scar tissue at the back of L4-5. So it is the same level and is a large disc which has migrated proximally also, and
Correct.
it definitely it's extruded. So I think there is no option at this point. How is there any deficit is there?
He's got L5 3/5 weakness.
Okay, fine. Then
But
there is
main
no
complaint is radicular pain. So he's
Uh-huh.
got right L5 radiculopathy.
No, given this larger disc, I think he requires surgery, and I
Yes.
would offer him a discectomy with the interbody fusion.
Yes. So that's what I also thought if I should do a fusion, but I think maybe Guru would think differently and do only a discectomy here.
No. I definitely this is a revision case with such a huge migrated disc which is going up. I would also definitely do a fusion, not just discectomy.
And why is that?
No, because you see, first of all, it's a revision case, and to fetch out these fragments which are migrating upwards, you need much more wider decompression, and I would expect because of some scarring, the retraction of the nerve root will be limited. So to do that, I would need a complete laminectomy to go up till maybe till the L4 pedicle. So I would not just take a chance here. And with these massive kind of disc herniation, I know that when I go inside, my disc is going to be empty there. So it is going to collapse further. So I would do a fusion, not just do a discectomy.
Yeah, I think I agree with you that the disc may be a little empty and you know there will be scarring, and also to prevent recurrence because it's already recurred in a year's time. But doing a decompression, I mean, because it's a discectomy done at L4-5, the proximal fragment has not been touched much, the proximal area of the spine. So you can remove the spinous process and get the fragment out without actually needing a fusion here.
So can we take opinion of Dr.
Right.
Gaurav and Dr. Binod as well, what they think in Nepal about this?
Dr. Gaurav, are you here?
Yeah, I'm here. Yeah, thank you. So I think I concur with what previous speakers. It's a huge disc, and I think for me, it's now straight away interbody fusion with decompression. Yeah.
Let me say
and
that
you would do posterolateral mostly or TLIF only here?
TLIF. Do a wide decompression TLIF. Take out the disc.
Okay. So I'll just go ahead. Basically, what we did was So I have done a decompression and a stabilization. So after we opened this up and put the screws in, I then went in on the right side because this was a right-sided disc and started trying to do a discectomy. But the extruded fragment I could not find. So I was actually looking for it. We tried to remove that disc part, but it was not adequate. It did not match with the MRI finding. So in a case like this, I mean, I understand sometimes it gets pushed to other side. It can be a little difficult to find them, but Dr. Badani, where are the places where the fragment could be hiding? And is it seen that it sometimes does not match with the MRI?
So I think if a lot of time has elapsed between this MRI and trying conservative treatment, say 2 to 3 months sometimes get elapsed before the patient actually comes up on the table. Sometimes there can be resorption of these discs. Secondly, quite often there is hardening of the disc inside. Just it lifts up the periosteum or sometimes the annulus and goes under, more so distally, less so proximally. But in those cases also you will find a lot of calcification and the disc might not be visible. So that could be a second reason. There are two things, and of course level identification would have been done, I assume. So wrong level is not the issue here. So these are two things I feel that the disc might not be visible. Actually, it is there, but it is so calcified and hardened that you might not be able to differentiate it from bone. Sometimes that is the issue.
Yeah, Guru, I don't want you to answer. I don't want you to answer in this. I want Dr. Binod. I'll tell you the reason later. I want Dr. Binod to be here. If you're there, can you just give your opinion about where it could be hiding the disc here? Or Dr. Gaurav?
I don't know, maybe it was in the, did you approach it from the right side? Maybe it was pushed all the way to the opposite side. I don't know.
Yeah. So yes, I did look at the opposite side as well, and we did not find the disc there also. Went proximally and checked it out, and saw that there was no calcification at that area.
Sometimes it could be
we were thinking
intradural, Satin. We have a large series, one of the biggest series. We published 7 cases intradural.
That's why I was asking Guru to keep quiet.
One of them is from Guru, from their center, and 6 from mine. So 7 cases we have published like this. So I kept quiet till everyone.
That is why
you couldn't hold it anymore.
That is why he didn't wanted me to answer.
Yes. Yeah, Ayush, you have to learn premature nahi hona chahiye. So okay, so I also noticed here that the dura was a little bit projecting outward, and it was not looking normal. So we went in and actually opened up the dura and found that there were the fragments were actually intradural in this case. And so I did a removal of all these fragments. Guru, so in this case, when you do open this up, what are the pointers? What are the things that you have to be more careful about in rather than a normal case where you open up?
So basically, try to allow the disc to come out by itself. Don't try to fiddle around too much there. And usually there, because it's an intradural, it's completely basically it's free. So it as soon as you open, it starts prolapsing out. But then just be careful. Sometimes it is connected still with the disc space. So that you have to be sure before you make the durotomy whether you're able to retract the thecal sac or not. If you're not able to retract the thecal sac, that means the disc is still in connection with the parent disc. So in that case, you have to be very careful when you plug this out, and always dissect it from the midline rather than if you see the disc onto the periphery. Don't try to elevate the root onto the periphery. Always try to take it from the midline. So that way you can prevent a lot of retraction onto the rootlets and prevent the damage.
One comment.
Yeah.
Yeah. So, one of the things which you should always do, if you don't find a disc and a case like this, just palpate the dura. You will always see that disc, hard disc there. That is how we have gone about it. You see a situation like this where you don't find anything, just put your finger, you all by now what Satin has done, you must have opened it completely. Just palpate. You can literally feel the disc fragment, and then you do what Guru told. So that has been our experience.
Yeah. Ankur, any opinion about the opening, how this disc condition would have gotten to the intradural?
Well, I think because it's a revision case, plus, these discs are quite, let's say, chemically active, and they can cause ruptures in the dura from behind. They can cause, and they can enter. It's a rare phenomenon, but it does, it can happen. But if you want to shed more light on what's the mechanism, I have not really read about it. So,
and one more thing, if you're not able to retract your thecal sac, don't try to retract it, because ultimately you cause anterior tears. And if it is stuck to the annulus, leave it there. Just remove the disc and come out, because that takes away your chances of having an anterior epidural CSF leaks. So just don't fiddle around too much. Just take out the disc and come out.
So Gaurav wanted to say something. Okay. I think let's have a comment from Gaurav and maybe move on to the next case. Here we are just running a little bit short of time. Yeah, Gaurav, please go ahead.
Yeah. So I just wanted some clarifications. After you remove the disc, do you go anteriorly through the rent in the dura, or do you go posterolaterally?
No, don't go anteriorly into the rent into the dura. It's just to be left as it is, and it will heal. And if it is still retractable, you have some anterior leak also, you can just pack it with the glue and then just come out. Okay. You can't do anything anterior epidural space.
Just one comment. So, it is very common in L4-5, because at L4-5, the annulus, your pulposus and disc are sort of very close together. They are like a single fragment. Yeah. So when the disc prolapse sometimes happens at L4-5, it goes from completely into the dura. So that's why it's most common in L4-5. And a lot of things, but I think it's better if you just read the paper. we have one of the biggest series for interdural disc. It is an Asian Spine Journal. You can just read the paper on that.
Yeah, so I'll just conclude it here. Basically, the mechanism for these extrusions to migrate intradurally is because of chronic irritation. If it's a central disc or a large disc which is irritating the dura, it can gradually thin it out and go intradurally. Most of the times, the anterior rent does close spontaneously on its own. And even in this case of ours, we were not even able to identify the anterior rent. So had to leave it alone and just close the posterior durotomy, and there was no issue with the CSF leaks at all. And I think I'll just stop here. Thank you.
Thanks, Satyan. It was really interesting. So we move on to the next case. The next case is going to be presented by Dr. Prem Shahi. So Prem, I'll be sharing your screens, sharing your slides, and then you can start talking. Yeah. So okay.
Okay, thank you so much, Ankush sir. Good morning, everyone. So thank you so much for inviting us in this collaborative course of ASSI and the ASSN. So let's go through my case. So my case is a 48 years female presented with pain radiating to bilateral lower extremities. It's more on left sides for last 2 months. And the patient also had a low back pain. The pain was sudden in onset, severe in intensity, more with activities and spine movements, and relieved with rest and medications. And she gives history of lifting of an object 2 months back. Walking distance is about 10 minutes. And on clinical examination, so the patient had the positive SLR that was significant, and the BAS score was 8 for leg pain and 2 for back pain. And the patient had a neurodeficit. L4 was 3/5 on left side and 4/5 on right side. And the patient also had saddle anesthesia. So here we have the X-rays of the patient. Can we move to the? So this is the plane skygram of the anteroposterior view and the lateral view. There is some decrease in disc height at the L2, L3 level, and there is no otherwise significant abnormalities in this X-ray, and a little bit of list, which is not that pertinent. And this is the MRI scan. So can we go to the next Excel cut, sir? MRI scan. So can we go to our panelist to comment on this societal T2 images of the MRI? Dr. Ayush?
Yeah, so definitely, I think L3-4 there's a disc prolapse, but which is of course the L4 root is getting involved more on the left side. Can we have the axials, please? Yeah, so can we zoom it on that?
Yeah, we have next slide.
Yeah, next. Yeah. So if if I remember correctly, you have more deficit on the left side compared to right. Is it? Am I correct? Yeah.
Yes.
To me, it looks like a central thing as of here, and both are equally affected. Maybe slightly more on the left compared to the right, but it's sort of a central prolapse, and it is involving both the sides. So that is my at least take on this.
Okay, thank you, Dr. Ayush. So can we move to the next slide, sir? So this is MST2A grade 2A, and next, sir. So here is another case with a large central disc herniation, but there is no cauda equina syndrome. The patient has bilateral leg lower limb radiculopathy. So can you move to the next one, sir? So my queries to the panelist is, so how to define a disc as a large disc? Though Dr. Guru has already mentioned the 50% of more than 50% of canal compromise is considered as the large disc. So what would be the criteria, or is there any cutoff line? Is it the size or anything like compression on the cord? So how can we define the disc as a large?
Yeah, as I already mentioned, it's basically the disc size to a canal dimensions. So if it is more than 50% of the canal occupancy, so it's considered as a large disc. So that's it about it.
Okay, sir. So the size of the disc has very poor correlation with the clinical presentations and all. So does the size of the disc matter in terms of clinical presentation of the patient or in terms of outcomes of conservative management? Is there any guidelines like this much of disc can be conserved, or this large disc has to be planned for surgery? So is there any cutoff line on based on sizes, sir?
More about the clinical presentation. Any disc could be conserved as long as patient is ready to tolerate or is comfortable with it. The moment patient either he cannot tolerate or you have a deficit, whether it's a small or large disc, you have to consider intervention. But large disc is sort of has other problems, like if you have removed too much of disc, you might have a sort of a collapse or intervertebral space, which might lead to other problems. The large disc, like as mentioned before, if you have removed too much, you have to do, it's a big annual rent. It can lead to reprolapse. These are the problems. But when it comes to whether conserving them or surgically intervening, I think most of us will agree it is more of a clinical decision rather than it's related to the size of the disc.
Can I make a point?
Yes, Arvind.
Yeah, so it's a heterogeneous group. Large central disc herniation or large herniation is not homogeneous. It's a heterogeneous group. In terms of the consistency of the disc, whether it is soft or hard, in terms of the symptomatology, whether it is discogenic or in terms of whether it is a flexion dominant or extension dominant pain, whether the annulus is calcified or not calcified, whether there is a tail to it on one side or whether it is only a central large disc, age of the patient. So it is a very heterogeneous group, and it has to be individualized.
So that's what I mean.
Whether there is axial back pain associated with it, not associated with it.
So that is what I was mentioning. What, as you mentioned, whether it's a broad based or it's a very narrow based, it also makes difference whether it is central or it's paracentral. And most of the times, the central large discs are don't correlate as much as with the pain. But then the large paracentral discs with the tail, they have the maximum severity of the pain. So as Dr. Arvind mentioned, most of the times they do correlate with the size of the disc with the symptomatology. But then, yes, sometimes you see a huge disc and patient doesn't have any symptom. So that can also happen.
Okay, so that means though the disc is too large, they can safely be managed conservatively, right?
Yes, yes.
Next slide, sir. So this is a beautiful paper published in AOA Spine Journal. So no statistical association was noticed between the size of the lumbar disc herniation and the likelihood that a patient will fail conservative treatment. And here are a few more papers also. So can we move to the next slide, please? So then if the size does not matter, is there any role of resorption of the disc based on types of the disc prolapse? For example, the protrusion or extrusion or sequestration. Is there any differences on the natural courses on the resorption, sir?
Definitely, sequestration has a better natural course, and they do reabsorb or absorb very faster as compared to a disc which is connected with the parent disc. So sequestrated disc have a better natural course of basically prognosis.
Basically, any as such is never comes in contact with your with your blood parameter or the inflammatory markers. So that is why when they come out, they have a lot of inflammation and leads to. So any disc which is much out, like sequestered, or when they can be attacked and phagocytosed, they are more likely to naturally resorb than compared to those who are contained inside the disc material.
And equally, sequestrated fragments do give a lot of pain. So because of the same reason, because they have a lot of inflammation. So if the patient can tolerate that severe pain for some time, they do resolve.
Yeah, I agree.
Okay, Satyan sir, so what's your take on there is a verdict like the compromise in the canal is not of that big concern, but the big concern is the compression at the thecal sac. So what's your take on that, sir? Satyan sir?
Satyan?
Ankur can take it, Ankur.
Okay, Dr. Ayush, what's your take on that?
On the large central herniation. So see, we all know that they all reduce in size. The problem is like developing chordoicoina. It's very as your literature rightly points out. It is they do reduce in size. The only problem with they sort of have a chronic back pain sort of thing. As they reduce in size, the disc also collapses, and that is what I have seen. In terms of the symptom, they go down, but they remain your patient with a chronic back pain, and that is what is my experience with this.
And so when the surgery is indicated, for example, what sort of patients, what type of disc, or so how can you decide what this sort of patients has to be gone for surgery?
So absolute indication is neurological deficits. So that's an absolute indication for operating on these patients. Rest all can be managed conservatively with individualized approach, depending upon the demand, depending upon the severity of pain, depending upon the duration. So unless there is no neurological deficits, rest all can be managed conservatively. And the approach has to be individualized depending upon the patient to patient.
Okay, sir. Guru sir has already mentioned. So there is a older studies or old thought is that the fusion surgeries is has good outcome with this large disc herniation. But we have seen one publication by Arvind sir regarding the only discectomy has also the very good outcome in this last central disc herniation. So what's your take on this, Guru sir?
So that is why the literature can be different and different people can have a different outcomes, because as Dr. Arvind rightly pointed out, these are very heterogeneous group of patients. So ultimately we have to see the majority of the cohort of patients, what kind of patients were they. So again, the literature which you are quoting, the regional differences also are huge. Compared to Western to Indian, where the mentality is totally different, because the outcomes are clinical outcomes are totally on patient to patient and how they perceive their problem. So that is why unless you compare Indian study to Indian study, you cannot really compare Western study to Indian study. So that's why it cannot match.
Can I make a point? So we basically, once such a patient is in a clinic in front of our eyes, so unless approach is an issue, for example, if it's a small facet with a large disc, if approaching is an issue where you'll have to do a facetectomy to remove the disc, but in general, we classify them as back dominant pain and a leg dominant pain. That is highlighted in a paper also. So if it is a back dominant pain, the tendency is usually to do a fusion. This is not buttock pain. This is back pain. Axial back pain is more significant than the leg pain. So the thing is that the discogenic leg pain. So there we fuse. But if it is purely leg pain, buttock down, then it is discectomy. And I mean, we have not seen high incidence of recurrence or post-operative back pain in such patients.
Prem, we need to finish. We are already 10:20.
Okay, sir. So in these two categories of patients, so the first one is having a large disc, but not that large, but with saddle anesthesia and without degenerative changes. And the second case is with little bit of modic changes and very large disc, but neurologically there is no significant deficit. So how can we approach in these two types of categories of patients, sir?
Ankur, you can answer that, and then can we wind up the session?
Can you just repeat the question? Sorry, I think I was a little distracted. Can you repeat the question, Prem?
I have shown the two cases. The first one is with large disc, but there is significant degeneration, and the patient had saddle anesthesia, impending chordoicuina syndrome. and the next case
Sure.
is having very large disc but without neurological deficit and with some sort of
Yeah.
modic changes. So how can we proceed in these two types of cases?
So, frankly, yeah, again, I think my decision making will be more based on clinical criteria than radiological criteria. That's for sure. So, the cauda equina syndrome definitely requires a surgery urgently, right? The impending cauda equina. Now, whether I'll do a fusion or a decompression alone will largely depend on what the symptomatology associated with that is. If there is patient has a lot of back pain, if there is any sort of instability which I'm looking at, then I would like to sort of fuse the patient. However, we know that these degenerative discs usually are inherently stable and these are chronic discs. And if I have enough space, then I may just like to decompress. On the other hand, the other case with no deficits and only pain, probably I'll wait and see if he improves with time and, may offer a non-operative treatment for the patient and see how he goes.
Okay, thank you so much, sir. So we had done the wide discectomy on first case and the only discectomy for the second case. Thank you very much.
Thank you.
All right. I think that brings us to the
vote of thanks, and then we wind up this session.
Yes. Yeah, so I'd like to thank all the participants, faculty from Association of Spine Surgeons of Nepal and also from ASSI. And we'd like to thank the Bombay Spine Society for organizing these outreach program webinars. I think it's a fantastic idea. It has brought us closer together with a lot of societies all over the world. And probably, this would be the way forward in the coming times as well. So thank you all, everybody. Any closing thoughts by Dr. Ketan, sir, please?
Yeah, it was a very, very interesting session, very exhaustive, and a lot of good points were discussed. And as you rightly said, our association is trying to, get all the societies together and have these kind of programs. And it is truly ASSICon before the ASSICon. And it was a wonderful session. And I really thank the Association of Spine Surgeons of Nepal for joining us and making this a very interesting session. Thank you, Dr. Binod and his team. And thank you all from ASSI and all the faculties.
Thank you. Thank you. Ortho TV, we can close the
Thank you, everybody. Thanks. Thank you.
Thank you,
Have a
sir.
nice day.
Bye.